Hi guys, you just can't get away from Miss Mock and I, and here I am in your house for your lecture on Chapter 35, Skin Integrity and Wound Healing. You probably remember this from A and P, but just a little bit of an overview of the structure of the skin: epidermis, dermis, subcutaneous layer. The epidermis consists of two main layers of cells that make up the skin: the stratum corneum. That's the skin's outermost layer that interfaces with the outside world. It's the primary barrier that keeps unwanted material out and protects from excessive loss of water. And then the stratum germinativum, the generative layers of cells that move outward and replace the stratum corneum. The dermis is that layer of skin that contains blood vessels, lymph vessels, hair follicles, and glands that produce sweat and sebum. And then, of course, the subcutaneous layer is the inner fat layer. Age affects the condition and structure of the skin. Infants and young children, as well as older adult skin, is thinner, more permeable than that of adults, which predisposes infants to skin breakdown. Patients are at risk for developing pressure ulcers, especially if they have immobility factors, friction and shear, moisture, incontinence, poor nutrition, poor perfusion, their age, we've talked about, skin condition, and altered level of consciousness. The older adult skin is less elastic, it's drier, it does have reduced collagen, has areas of hyperpigmentation, and they're just more prone to injury. The Wound Care Education Institute defines friction as when two forces rub together, leading to a superficial, partial thickness skin injury that looks clinically like an abrasion. For example, if you've got a patient in bed that's agitated or restless and continually rubs their feet against the sheets, there's no pressure involved, but the constant friction will cause epidermal damage or sheet burn. Shearing, on the other hand, is what you get when you have friction and then you add it to the force of gravity. So let's think about a patient that's in bed, the head is raised. As the weight of the gravity pulls down on the skeleton towards the foot of the bed, his skin might be stuck on the mattress due to friction, and as his bones slide down, vessels in between the skin and bone can become compressed, stretched, and or torn. This causes a lack of blood flow to the tissue, leading to ischemia, and this is how we end up with a full thickness wound. So it is important to understand what happens with friction and shearing. Shearing gets down into the epidermal layer and can really cause problems for the patient. This and the next slide is the article. It's a blog from the Wound Care Education Institute if you want to read the full article. Healthy skin is going to depend on adequate nutrition and hydration to maintain good skin integrity. Protein is incredibly important. It maintains the skin, it repairs minor defects, it preserves intravascular volume, and with inadequate amounts of protein, you are going to have a hard time with especially wound healing. So as a nurse, you're going to be monitoring the serum albumin levels in the blood. And if they are not within normal range, then you need to consider nutrition as a factor in a wound that is not healing. Adequate protein levels maintain the skin and repair minor defects. Vitamin C, zinc, and copper are also involved in collagen formation, and deficiencies of that may impair healing. Dehydration results in poor skin turgor, and edematous skin as well can be prone to injury, especially when exposed to pressure, shearing, friction, and moisture. Also, when you have a patient that has diminished sensation, obviously someone who has maybe diabetic neuropathy or who has any kind of paralysis and diminished sensation, that can lead to increased pressure, and you can have skin breakdown because they can't feel the pain like you and I do. We shift our position when we start feeling that discomfort. People with decreased sensation do not do that. Impaired arterial circulation restricts activity, it produces pain, and it leads to muscle atrophy and development of thin tissue that is prone to ischemia and necrosis. Impaired venous circulation results in engorged tissues with high levels of metabolic waste products that are prone to edema, ulceration, and breakdown. Both forms of circulatory impairment will delay wound healing, and in fact, circulatory impairment is one of the main causes of chronic wounds. Certain medications that cause pruritus, which is another word for itching, dermatosis, which is another word for rash, photosensitivity, alopecia, or pigmentation changes can result in changes that impair the skin. Other factors that can affect skin integrity are maceration, and you may not know what maceration is, but anytime you've left your hands in water too long, you get maceration. It's just a softening of the skin, and usually it is a result of exposure to moisture, and it does increase the likelihood of skin breakdown. Incontinence and fever are the most common sources of moisture. Fever depletes. It leads to sweating. That can cause maceration. It also increases the metabolic rate, which raises the tissue demand for oxygen. And increased demand for oxygen is difficult to meet if you've got circulatory impairment or tissue compression secondary to pressure. So you can see how that could result in a breakdown in the skin. Infection can also impede healing. Infection implies that the microorganisms are causing harm by releasing toxins, invading body tissues, and increasing the metabolic demand of the tissue. Infection of the skin makes it more vulnerable to breakdown and impedes the healing of open wounds. If it's not stopped, bacteria then can gain access to the systemic circulation, and you can have a patient that becomes septic. Lifestyle, a few different things that we can talk about. Tanning exposes the skin to ultraviolet radiation, thereby increasing the risk for skin cancer. And bathing, frequent bathing and use of soap removes skin oils and may lead to drying, which jeopardizes the skin's barrier function. Infrequent cleansing of the skin can contribute to excessive oiliness, clogged sebaceous glands, and inadequate removal of microbes on the skin, which then can infect a wound or a lesion. Body piercings and tattoos represent a risk for infection and scarring. Complications which occur in about 20% of piercings include local infections, sepsis, endocarditis, hepatitis, and toxic shock syndrome. Here you have a little bit of a knowledge check based on the slides we've already had of the following factors which would put a client at greatest risk for impaired skin integrity: medication and digoxin, moisture, decreased sensation, dehydration. Well, we know from the previous slides that all of those things could cause impaired skin integrity, so let's look at the next slide and see what the answer is. The greatest risk would be decreased sensation. That would greatly increase the risk for injury with a tear or break in the skin. This could lead to a delay in seeking treatment due to lack of awareness. Okay, let's move on to classification of wounds. You can have different types of wounds. An open versus a closed wound. A wound is considered open if there is a break in the skin or mucous membranes. Open wounds include abrasions, lacerations, puncture wounds, surgical incisions. If there are no breaks in the skin, then the wound is described as closed. A contusion or a bruise or tissue swelling from fractures are common closed wounds. Acute versus chronic wounds. Acute wounds are expected to be of a short duration. In a healthy person, these wounds heal spontaneously. They don't have complications throughout the 3 phases of wound healing, which are inflammation, proliferation, and maturation. and those are described in your book. Wounds that exceed the expected length of recovery are classified as chronic wounds. Those are really difficult to deal with. Clean versus contaminated versus infected. Clean wounds are uninfected wounds with minimal inflammation. Clean contaminated wounds are surgical incisions that enter the gastrointestinal, respiratory, or genitourinary tracts. There's an increased risk of infection for these wounds, but no obvious infection. Then you've got contaminated wounds, which include open traumatic wounds or surgical incisions in which a major break in asepsis occurred. The risk of infection is pretty high for these wounds. And then you have wounds that are considered to be infected when the bacteria count in the wound tissues are above 100,000 organisms per gram of tissue. However, the presence of beta hemolytic streptococci in any number is considered an infection. Then we have terms pertaining to the thickness of wounds. Superficial / partial or full thickness wounds. Superficial wounds involve only the epidermal layer of the skin. The injury is usually the result of friction, shearing, or burning. Then you've got partial thickness wounds, which extend through the epidermis but not through the dermis. Full thickness wounds extend into the subcutaneous tissue and beyond. Penetrating wounds is sometimes added to indicate that the wound involves internal organs. In monitoring wounds, you need to look at the types of wound drainage. It gives you important information about the wound, and the different types of wound drainage available are serous, sanguinous, serosanguinous, and purulent. Serous is a straw-colored. We'll look at some slides on the next few slides of examples. Sanguinous is a bloody drainage. Serosanguinous is a mix of the bloody and straw-colored fluid, and then purulent is yellow and is a little thicker and contains pus. This particular slide shows you an example of serous exudate. Clean wounds typically drain serous exudate. It's watery in consistency, contains very little cellular matter, and consists of serum, which is the straw-colored fluid that separates out of blood when a clot is formed. This is drainage in a Jackson-Pratt drain. This is an example of sanguinous drainage. It's bloody drainage. It is usually found with deep wounds or wounds that are in highly vascular areas. Sanguinous exudate is just frankly bloody drainage. It indicates damage to capillaries. Fresh bleeding produces bright red drainage, whereas older, dried blood is a dark red-brown color. Serosanguinous is a combination of bloody and serous drainage. So if you've had a wound that has gone from sanguinous to serosanguinous, which is the usual progression, and then it goes back to sanguinous, which is bloody, you know that you likely have some type of bleed going on, because it should get more serous in nature as the wound heals. This is an example, several examples of purulent drainage. This is thick. It's often has a foul odor, drainage that is seen in infected wounds. It contains pus, a protein-rich fluid that's filled with WBCs, bacteria, and cellular debris. It is commonly caused by infection from pyogenic or pus-forming bacteria such as streptococci or staphylococci. Normally pus is yellow in color, although it may take on a blue-green color if the bacterium Pseudomonas aeruginosa is present. In this particular picture, you see it's dried. Here you have purulent material from an ear, probably a rupture of otitis media, and then you've got kind of stringy purulent drainage here in an eye, which is probably a result of bacterial conjunctivitis. Let's talk about the wound healing processes. Regeneration is when a wound affects only the epidermis and dermis, and regenerative epithelial healing takes place. There's no scar formed, and the new regenerated epithelial and dermal cells form new skin that cannot be distinguished from the intact skin. Partial thickness wounds heal by regeneration. Then there's primary intention when a wound involves minimal or no tissue loss and has edges that are well approximated. Primary or first intention healing takes place. There's little scarring expected, and a clean surgical incision heals by this method. Then there's secondary intention. Healing by secondary intention occurs when a wound involves extensive tissue loss, which prevents the wound edges from approximating or coming close together, and it should not be closed because it is infected. Because the wound is left open, it heals from the inner layer to the surface by filling in with beefy red granulation tissue, which is a form of connective tissue with an abundant blood supply. Wounds that heal by secondary intention heal more slowly, they're more prone to infection, and they do develop more scar tissue. Pressure ulcers and infected wounds are examples of this. Then there's healing by tertiary intention. A wound heals by tertiary or third healing, also called delayed primary closure, which occurs when two surfaces of granulation tissue are brought together. This technique may be used when the wound is clean contaminated or actually contaminated. Initially, the wound is allowed to heal by secondary intention. When there is no evidence of edema, infection, or foreign matter, then the wound edges are closed by bringing together the granulating tissue and suturing the surface. Such wounds require strict aseptic technique during all dressing changes because they are prone to infection. Tertiary intention healing creates less scarring than does secondary, but more than primary intention healing. There are numerous complications of wound healing. Hemorrhage, of course, is one. The risk of hemorrhage is greatest in the first 24 to 48 hours following surgery or injury. Swelling of the affected body part, pain, and changes in vital signs such as decreased blood pressure and elevated pulse may indicate internal bleeding. By internal bleeding in this particular chapter, we are referring to a hematoma, a red-blue collection of blood under the skin which forms as a result of bleeding that cannot escape to the surface. External hemorrhage is, of course, easier to recognize. You'll see bloody drainage on the dressings and in the wound drainage devices. When there is a brisk hemorrhage, blood often pools beneath the client as the dressings become saturated. Then you've got another complication, which is infection. Infection is defined as localized swelling, redness, heat, pain, fever. Temperatures are usually higher than 100.4 Fahrenheit. Foul smelling or purulent drainage or a change in the color of the drainage may also indicate infection. Then a couple of other things that can occur, and you need to know the difference between these, are dehiscence, which is rupture or separation of one or more layers of a wound. Wound dehiscence is most likely to occur in the inflammatory phase of healing before large amounts of collagen have been deposited in the wound to strengthen it. The most common causes of dehiscence are poor nutritional status, inadequate closure of the muscle, or wound infection. This is an example, and you can see it's not completely opened. Evisceration, which is this example, is a total separation of the layers of a wound in which internal viscera protrude through the incision. This is a rare complication, but it is a surgical emergency. Your first action is to immediately cover the wound with sterile towels or dressings that are soaked in sterile saline solution to prevent the organs from drying out and becoming contaminated with environmental bacteria. You want the patient to stay in bed with their knees bent to minimize strain on the incision. The surgeon is to be notified and you ready the patient for a surgical procedure. Then you've got fistula formation, another complication that's an abnormal passage connecting two body cavities or a cavity in the skin. Fistulas often result from infection, and abscess forms which breaks down surrounding tissue and creates the abnormal passageway. Chronic drainage from the fistula may lead to skin breakdown and delayed wound healing. The most common sites where fistulas form are the gastrointestinal and genitourinary tracts. Here's a clicker check. The client calls the nurse to the room and states, "Look, my incision is popping open where they did my hip surgery." The nurse notes that the wound edges have separated 1 centimeter at the center, and there is straw-colored fluid leaking from one end. The nurse's best action is to 1. Notify the surgeon stat, 2. Place a clean sterile 4x4 over the incision and monitor the drainage, 3. Wrap an ace bandage firmly around the area and have the client maintain bed rest, and 4. Immediately cover the wound with sterile towels soaked in normal saline and call the surgeon. And the answer is B, a 1 centimeter separation of wound edges only in the center of a surgical incision on the hip is too small to truly be termed dehiscence. Even if there were a large separation, there are no internal viscera to protrude. Okay, so part of your job as a nurse is assessment of skin and wounds. You will be doing many focused skin assessments to assess wound healing ability and the risk for skin breakdown. You need to gather data on factors that are going to affect skin integrity, which we discussed previously. Age, mobility, nutrition, hydration, sensation, circulation, medication, and etc. The psychosocial issues related to coping with chronic wounds also needs to be considered. The Braden scale, you will use that in the nursing home, but it can also be used in any setting where the patient may be at risk for developing skin breakdown. The Braden scale evaluates 6 major risk factors: sensory perception, their ability to feel pressure, moisture, activity, mobility, nutrition, and friction and shear, which we also discussed earlier. The final score reflects the patient's risk. The lower the score, the more likely the patient will develop a pressure ulcer. A score of 18 or less for hospitalized patients indicates risk. Intervention should be based on the individual risk factors as well as the total score. You should use this scale to assess the patient on admission to the facility and again in 48 to 72 hours. When assessing an actual wound, there are numerous things that you're going to have to not only assess but document thoroughly. Location is the first thing. Describe the wound location in anatomical terms. Other important factors related to locations are location influences the rate of healing. If you have a wound in a highly vascular region, such as the scalp or hands, they may heal more rapidly than wounds in less vascular regions, such as the abdomen or a heel. Also, wounds that can be readily stabilized heal more rapidly than those in areas that are affected by the constant stress of movement. Location can give you clues to the wound etiology. A wound over a bony prominence could be related to pressure, whereas one on the bottom of the foot could be a diabetic ulcer. Another thing that you're going to want to assess is the size of the wound. You're going to measure the length and width of the wound in centimeters. Typically, we do that using a head-to-toe orientation where the longest length head to toe and the widest width side to side are documented. You may also want to, and we will show you how to do this when we do wound care, measure the depth of the wound as well. You want to assess and document the appearance. What does the skin around the wound look like? It's called peri-wound. Examine the skin surrounding the wound. Skin discoloration may indicate a hematoma or additional injury to the surrounding tissue. You want to look for maceration. We talked about that earlier. Undermining crepitus, blistering, erythema, slough, eschar, and any signs of streaking, red streaks that could indicate infection. You want to assess the drainage. We've talked about the different types of drainage, not only the color and the type of drainage, but the amount, are there drains present, and odor. Other things to assess for are wound and tissue pain and nutritional status. Redness, another word for redness is erythema, and swelling or other signs of irritation indicate that the surrounding tissue is in jeopardy and needs to be addressed. In caring for a wound, oftentimes that involves cleansing or irrigating it. Another word for irrigation of a wound is lavage, and we do that by gentle flushing. To remove debris from a wound, you introduce an irrigation solution with a mild amount of force. An ideal irrigation pressure ranges from 4 pounds per square inch to 15 pounds per square inch. To remove material adhering to the wound bed, you will use a 35 milliliter syringe attached to a 19 gauge angiocatheter and deliver the solution at approximately 8 psi. Pressures above 15 psi increase the risk of driving bacteria into the tissues as well as causing mechanical damage. We will demonstrate this when we do wound care. Another thing that's involved, we care for drainage devices. We will show you those drainage devices. The one in this particular picture is a Jackson Pratt. It does work by opening the drain. It is sutured in to an area close to the surgical site typically. You compress the drain with the drain open and then close it, and that creates a vacuum which draws out fluid. Also, debriding a wound, this is usually done by either the physician or maybe done through particular dressings that you use, or they may go to physical therapy for this. Debriding a wound is the removal of devitalized tissue or foreign material from a wound. It also helps remove cells that are alive but not functioning from the wound bed and edges. Removal of necrotic tissue, exudate, and infective material helps stimulate wound healing and prepare the wound bed for advanced therapies or biological agents. Different types of debriding include sharp debridement. That's the use of a sharp instrument such as a scalpel or scissors to remove the tissue. This method provides an immediate improvement of the wound bed and preserves granulation tissue. Then there's mechanical. This may be performed via lavage, the use of wet to dry dressings, or hydrotherapy in a whirlpool. Enzymatic is the use of proteolytic agents that break down necrotic tissue without affecting viable tissue in the wound. To use an enzymatic product, you want to clean the wound with normal saline, apply a thin layer of the cream, and cover with a moisture-retaining dressing. Then there's autolysis. This is the use of an occlusive, moisture-retaining dressing and the body's own enzymes and defense mechanisms to break down necrotic tissue. This process does take more time than the other techniques, but it is tolerated better. The procedure involves applying the dressing and observing the fluid that collects under it. The dressing is normally changed every 72 hours, and at that time the wound is cleaned before a new dressing is applied. There are many types of wound care therapies. Applying negative pressure wound therapy involves healing by secondary and tertiary intention. Using a specialized pump, negative pressure is placed on a wound packed with foam or gauze dressings that creates a vacuum. The subatmospheric pressure improves wound healing by decreasing the edema in swollen tissues, promoting granulation tissue formation, and removing exudate and infectious material. You have some pictures of that, I believe, in your book. There are also numerous types of dressings for a wound. Transparent film dressing allows exchange of air and water vapor between the wound and the environment while preventing external bacterial contamination. They are useful for wounds with minimal or no drainage, and they're often used to dress IV sites. Gauze dressings, there's numerous different types of those. Some are impregnated with antimicrobial agents, medications, or moistures, and others contain petroleum to keep the wound moist. Gauze can be used in combination with amorphous hydrogels, saline, or medications. Gauze dressings can be used for packing large wounds, cavities, or tracts, deep or dirty wounds, or heavily draining wounds. Then you've got hydrocolloids. These are wafers, pastes, or powders that contain hydrophilic, which are water-loving particles. When they're applied to a wound, the hydrophilic particles interact with exudate to form a gel that keeps the wound moist. The dressing forms a protective layer against friction and bacteria. This type of dressing is ideal for wounds with minimal drainage, such as partial thickness wounds or stage 2 pressure ulcers. Hydrogels are sheets, granules, or gels with a high water content, creating a jelly-like consistency that does not adhere to the wound bed. They have a soft, cooling texture that promotes patient comfort. Hydrogels enhance epithelialization by providing moisture to the wound bed, and they may also be used to soften slough or eschar, which is dead tissue in necrotic wounds, and they can be used in infected wounds. Supporting and immobilizing a wound, binders and bandages are used to hold a dressing in place, apply pressure to a wound to impede hemorrhage, and support and immobilize an injured area, thereby promoting healing and comfort. Before applying a bandage or binder, determine the intended purpose of the application and assess the part being bandaged. You will want to look up Montgomery straps, which are often used for large abdominal wounds that have to be changed frequently, and they are basically straps that have adhesive with ties on them, and so the adhesive doesn't have to come off every time. You just untie the bandage, change your dressing, and then tie it back over to immobilize the bandage. We'll show you examples of that in class. Application of heat and or cold is also a common nursing intervention related to wound care. Heat therapy can be moist heat, which is soaks or baths with moist heat, or a washcloth or a towel, or it can be dry heat through like an electrical heating pad or disposable hot pack. And then usually heat therapy is used to relieve stiffness, discomfort associated with musculoskeletal problems, but it can also be used for patients that have wounds because it increases blood flow to that area through vasodilation. Cold therapy provides local anesthesia. It reduces cell metabolism. It decreases muscle tension. We use that a lot for any type of inflammation that may be going on. For both of them, you want to avoid direct contact with the heating or cooling device. You want to cover the hot or cold pack with a washcloth, a towel, or a fitted sleeve, and you're going to apply the hot or cold intermittently, leaving it on for no more than 15 minutes at a time to avoid tissue injury. You want to assess the skin frequently for redness, blistering, cyanosis, blanching, any types of damage that might be caused by the actual heat and cold therapy we want to assess for. Okay, pressure ulcers are a kind of a special component of wound care that we deal with. We play a major role in prevention and treatment. An estimated 1 million people in the United States have pressure ulcers. About 15% are hospitalized patients, 10% of home care patients, and 20% of long-term care patients. They are caused by unrelieved pressure to an area that results in ischemia of the tissue. Unless the pressure injury is present on admission, in most circumstances, Medicare will decline payment for treatment of that ulcer. Costs in lives can be high as well, with reported mortality rates of 70% for older adults within 6 months of an occurrence of a pressure ulcer. So it's really critical that we prevent these. In order to prevent them, we have to understand what the risk factors are for the development of pressure ulcers. There are certain intrinsic factors that alter skin and tissue integrity or oxygen delivery capabilities that decrease the amount of force required to create a pressure ulcer. Examples of this include Patients who are immobile or who have impaired sensation, that can occur with spinal cord injuries, stroke, coma, diabetes. Poor nutrition is an intrinsic factor, edema, aging, low arteriolar pressure where we have poor tissue perfusion and fever. Poor nutrition or dehydration can weaken the skin and lead to pressure ulcers. It's very important that adequate intake of calories, protein, vitamin C, and zinc be present in order to prevent pressure ulcers and promote healing of injured tissues. Extrinsic factors include friction. We've talked about how this damages the outer protective epidermal layer, and then pressure. Usually these areas are going to develop over bony prominences, but they can also occur under casts, splints, or other assistive devices. So we need to keep that in our mind when we're dealing with a patient that may have a cast or a splint, that they can develop pressure ulcers underneath those, and skin needs to be assessed underneath those particular devices. With that pressure, the skin is compressed between the bone and a hard surface of the bed or chair, reduces blood flow to the area, and most of the time our patients that develop these are in supine positions, and they develop over the occiput, the scapula, elbows, sacrum, and heels. We've talked in an earlier slide about shearing when the epidermal layer slides over the dermis, causes damage to the vascular bed, and we talked about how that occurs. And then exposure to moisture, especially in the form of urine or feces. Moisture macerates the skin and also decreases the amount of pressure required to produce an ulceration. Pressure ulcers are assessed and documented, and you need to determine the stage of a pressure ulcer. The stages are from 1 to 4. There are some good pictures in your book on page 910 and 911 that actually is a little bit better than this diagram. They are classified according to the amount of tissue involvement. Stages 3 and 4 involve actual tissue death. The push tool is an assessment guide that helps you to document, and you can find that in your Volume 2 book. I would go to page 910 and look at the various pictures. Stage 1 pressure ulcer is a localized area of intact skin, but the key is it has non-blanchable redness, usually over a bony prominence. In other words, when you press on an area of redness, normally it blanches white. When you let go, the blood returns to that surface. With stage 1 pressure ulcer, it does not blanch. May be painful, firm, soft, or warmer or cooler as compared to adjacent tissue. Discoloration will remain for greater than 30 minutes after the pressure is released. Stage 2 involves a partial thickness loss of dermis. So stage 2 pressure ulcers are open but shallow and with a red-pink wound bed. There is no slough. It may also be an intact or open or ruptured serum-filled blister, or a shiny, dry, shallow ulcer without slough or bruising. Stage 3 is a deep crater. It's characterized by full-thickness skin loss with damage or necrosis of subcutaneous tissue. It may extend down to but not through the underlying fascia. There may be undermining, which is a deeper level damage under boggy superficial layers. Bone and tendon is not visible or directly palpable. And then stage 4, it involves full thickness skin loss with extensive destruction. There's tissue necrosis or death. There's damage to muscle, bone, or support structures. The exposed bone and tendon is visible or directly palpable, and you may have slough or eschar present. Open your Volume 2 book and look for the push tool, and you can score this particular question. Prevention is really critical when it comes to pressure ulcers, and they can be prevented. It requires meticulous skin care, moisture control, um, sweat, urine, feces. The patient really needs to be kept dry. You need to assess the skin frequently. You need to assess their nutritional status. Are they getting enough vitamin C, protein, zinc? What are their albumin levels in their blood? Those things are critical to maintain either skin integrity or healing if a pressure ulcer has occurred. Frequent repositioning is also essential. If they are not on a therapeutic mattress, which puts different areas of pressure on different types of the body by movement of air, then they must be repositioned every couple of hours. For patients that are bedridden, this can be really difficult because they tend to like to stay in one particular position, and moving them can be a challenge. Use pillows, other devices to keep them repositioned. Client and family teaching are essential. Um, if a family member is being taken care of at home, they must understand the skin care, moisture control, nutrition, and repositioning aspects in order for a patient to not develop a pressure ulcer when being cared for at home. You need to conduct a pressure ulcer admission assessment for all patients and reassess the risk for all patients every day. Inspect their skin daily. As we've talked about, manage moisture, nutrition, hydration, and then minimize the pressure.